Good evening, everyone, and welcome to the webinar on the theme Empower India Summit. It gives me great pleasure to invite our program director, Dr. Niti Raizada, Senior Director, Medical Oncology and Hematology, Fortis Group of Hospitals, Bengaluru, to give the welcome and opening remarks. Over to you, ma'am.
Welcome to today's evening session, Empower India Summit on Endometrial Cancer. Firstly, I would like to take this opportunity to thank AstraZeneca and Kavina Creations for hosting the event. It's actually a very important topic because endometrial cancer still happens to be a very intriguing cancer for all of us, especially because of rapid changes, not just in staging, but in therapy. And some of the nuances we'll be discussing today by our speakers subsequently, followed by moderator and panelist. And our first talk, the keynote session, will be Unmet Needs in Endometrial Cancer and highlights on DOE study, which will be by Professor Dr. Vishwanath, who's a senior consultant medical oncologist at Apollo Group of Hospitals in Bangalore. Over to you, Vishwa.
Yeah, thank you, Dr. Niti, for that kind introduction. And we'll start the session with this first talk, which is on unmet needs in endometrial cancer and DOE study highlights. So if you look at the endometrial cancer, it is the 6th most common occurring cancer in women all over the world and 15th most common cancer overall.
It's not visible, sir.
Yeah.
It's not visible?
Share screen.
1 second, sorry. It's seen now?
Yes, yes.
Yes, sir.
And is it moving?
Yes, sir.
Yes.
Okay, perfect. Yeah. So endometrial cancer is the 6th most common occurring cancer in women and the 15th most common cancer overall. If you see in 2022, around 420,000 cases, new cases of endometrial cancers were reported with an associated close to 1 lakh deaths. And the number of new cases in women for the top 10 most common cancers, if you see, it's around 4.3% for the corpus uteri, which is the endometrial cancer. And 9.7, that translates to around 9.7 million new cases all over the world. And India, if you look at the Globocan data, if you look at the number of cases, 400, and this is Globocan 2022 to be precise. And percentage, it was only around 1.2%, and the cumulative risk is around 0.29. And if you see the number of deaths, it was around 6,385, and ranked 23rd. And the percentage of deaths are only 0.75, and the cumulative risk is 0.11. And the 5-year prevalence is around 43,080 cases. And the proportion per numbers, which may not be the true numbers, but this is the overall numbers which Globocan 2022 has captured. So we do know that just like any other malignancy, like breast cancer or any other solid malignancy, we have come to know through a lot of molecular panels that there is a lot of heterogeneity, and the classification of endometrial malignancy has significantly evolved. And both germline and somatic mutations may increase the risk of developing endometrial cancer. And we look at the MMR mutants, inherited autosomal dominant syndrome, which occurs in a small percentage of endometrial cancer cases, which is characterized by germline mutation in the MMR genes, which could be of MLH1, which is the most common, followed by MSH2, MSH6, and the least common is PMS2. And the guidelines do recommend that we should go for the molecular classification through immunohistochemistry from the MMR proteins on all the endometrial cancer samples. BRCA, slowly over a period of time, I'm sure in the next few years, BRCA may become a tumor agnostic indication. And we are seeing BRCAs in quite a lot of malignancies. In fact, recently we had a patient with leiomyosarcoma who had a BRCA2 mutation and is responding extremely well to olaparib. So, the association between germline BRCA mutation and the risk of malignancies currently remains uncertain. the link between PRCA1 mutations and uterine serous cancer has been suggested in small retrospective studies, but in others, there has been no major risk which has been implicated. Then there is something called the P10 mutation. Somatic P10 mutations are common in sporadic endometrial cancers, occurring in 37 to 61% of the cases, which is a big number. And germline mutations are rare and associated with Cowden syndrome, which can also present with hamartomas and polyposis, which occurs in 28% lifetime risk of developing endometrial cancer. So the two most common endometrial cancer staging classifications, the TNM and the FIGO, differentiate endometrial cancer's tumor staging according to the depth of invasion and the presence of metastasis. So we have localized disease, stage 1, stage 2, which occurs in around 67% of the patients, and regional disease in 20% of these. That is a stage 3, where we have lymph node involvement, and stage 4, which distant disease, it's around 9%. So the 5-year survival, if you see by stage at diagnosis, it's 67% for the localized disease, but the 5-year survival is quite bad, which is around 9% in the stage 4 disease, and that's hence the focus and where the major unmet need is. So the 4 major molecular subgroups of endometrial cancer defined by mutation burden and copy number alterations have been characterized by the TCGA, which is the Cancer Genomic Atlas. And the pole mutated, we know that these pole mutated patients, especially the pole exonucleus domain variation, these patients are ultra mutated. They can also be associated with very high tumor mutational burden, and they have a brisk lymphocytic infiltration, and hence the response to immunotherapy is just phenomenal and excellent prognosis with very low rates of recurrence. And then we have the MSI high, which is also the dMMR, again hypermutated P10 and the other mutations which can be seen, and then MMR defects and unusual histological morphology, but are associated with more uniformly endometrioid tumors. And again, they also have extensive tumor infiltrating lymphocytes, and we do know that MSI high patients or the dMMR patients have an extremely good response to immunotherapy. And then we have the copy number low, which is the no specific molecular profile, and P53 wild type. Again, they can have variants common in P10, CTNNB1, PIK3CA, KRAS, and AR, the other mutations, and they are usually MSS. It uniformly contains endometrial tumors of generally low grade, and the CTNNB1 mutations are associated with a worse outcome than expected from these tumors with favorable histopathological features. And then we have the last category, which is the copy number high, which are generally P53 abnormal, and P53 mutations are common. CCNE1 amplifications are common, and they are high-grade aggressive cancers, including uterine serous carcinomas and 25% of high-grade endometrioid cancers. And they have a high relapse rate, and they have prognostically they are very poor. So if you go from pole mutated to CN high, the prognosis worsens. So what is the major unmet need in advanced endometrial cancer? Surgery is the main treatment we know across stages, with adjuvant radiation therapy and chemotherapy, which is used to prevent local recurrence and systemic recurrence. And we know for stage 1, it is primarily the surgery in most of the patients, and adjuvant therapy is given after surgery to prevent recurrence. And we have the molecular profile to dictate whether the patient falls under low risk, intermediate risk, high intermediate, or high risk. And we do know that for patients with stage 1B, we also give additional radiation. Stage 2 also surgery followed by radiation, and stage 3 but again, these things are prior to the molecular profile era. But we do know that a patient with stage B could still receive pelvic radiation and chemotherapy depending on the overall risk profile. And then we also have the we have the stage 4 patients, where again debulking is possible. If it is possible, we go for surgery followed by systemic chemotherapy. If no debulking is possible, then systemic therapy, and then radiation could also be used for additional local control. And hence the overall paradigm shift in the way we are managing. While early stage endometrial cancer is highly curable after hysterectomy for most women, advanced metastatic and recurrent disease pose a significant challenge. And we're seeing the 5-year survival that only 17% of patients with metastatic disease survive for 5 years from the time of their diagnosis. And the risk of recurrence by stage, if you see stage 1, stage 2, it's only 5 to 15%. But if you see the stage 3 and stage 4, there's a significant, around quarter to 50% of the patients do recur. While early stage endometrial cancer is highly curable, so we have discussed this part. So patients with stage 4 disease are at highest risk of recurrence, and serous, clear cell, mucinous, and squamous cell represent a small quarter of the patients. These subtypes are at high risk, tend to be diagnosed later, and have a higher recurrence risk. And the first line standard of care chemotherapy is for patients with dMMR endometrial cancer is platinum chemotherapy plus IO. Due to multiple phase 3 trials that have been read out so far, we know the pembrolizumab lenvatinib data. We also have the pembrolizumab and the paclitaxel carboplatin data. And until the approval of pembrolizumab plus or minus lenvatinib and dostarlimab monotherapy, most recommended second-line regimens have been ineffective for treating these patients with advanced endometrial cancer, highlighting the unmet need for these women. With this background, let's talk about the trial in discussion for today, which is the durvalumab plus Taxol plus carboplatin, followed by maintenance durvalumab with or without the PARP inhibitor olaparib as the first-line treatment option for newly diagnosed advanced or recurrent endometrial cancer. So this is the microenvironment. Tumors can further be described as hot or cold. This has been going on for the last 10 years, ever since Onjo and James Allison from MD Anderson and Japan came up with this immune checkpoint inhibitors and the tumor microenvironment, where the immunogenic tumor microenvironment is considered as hot and non-immunogenic tumor microenvironment is considered as cold. The idea is to make a cold tumor hot and make it more inflamed. So by giving chemo, we're able to prime these chemotherapies, these microenvironments to become more hot and more inflammatory. So that way the immunotherapy works better. So the mechanism of immunotherapy, that is durvalumab and olaparib in endometrial cancer. So you have in a dMMR patient, there's a pre-existing immune response held in check by PD-L1 and inhibition of the T cells. And so in a prolific MMR patients, the biological heterogeneous population, diverse genomic drivers, and variable immune priming. So the immunosuppressive, you want to, the tumor microenvironment is quite diverse in these two patterns. So the whole idea is in the induction phase, in a dMMR patient, you want to give a standard of care chemotherapy. And we know that dMMR responds very well to immunotherapy. So you give durvalumab. So you give this combination, it drives a direct tumor cell killing and an enhanced immune response through blockade of PD-L1. And the blockade of PD-L1 with durvalumab drives prolonged anti-tumor immunity and durable clinical activity in these patients with limited potential for further enhancement. So what happens is in the pMMR, you give chemotherapy plus durvalumab. It drives the direct tumor cell killing and an enhanced immune cell response through the blockade of PD-L1. And the blockade of PD-L1 leads to more limited anti-tumor immunity in pMMR tumors. Hence, we have to see if there's anything else which can be added. So the rationale behind combining the durvalumab and olaparib, so there's a synergistic mechanism. So there's a potential synergistic activity of combining these two drugs. So if you give the PARP inhibitor along with the PD-L1 inhibitor, so there is another stimulation of another pathway which is called STING pathway activation, which again because of this pathway stimulation, then there is release of cytokines and chemokines and enhanced immunogenicity, and then you have an apoptotic pathway. You have the CXCL10 and CCL5, which get stimulated, and you have an apoptotic injury of these cells. And then you also have the accumulating DNA damage, transcription factors, and accumulating DNA damage leads to cell death, which is mainly through PARP through this combination. And then you have an increasing cell death through antigen release, and then increasing cell death, upregulation of various surface receptors like the T cell and NK cell. And then, of course, you have increased activity of in combination and increased activity, which is a synergism by combining these two drugs. So olaparib can also enhance the activity of durvalumab through its ability to promote an anti-tumor immune response. So you have the immunomodulatory drug, you have the activation of the STING and release of the Th1 cytokines, and the upregulation of the co-stimulatory cell surface receptors. And you also have activation of the NF-kappa B pathway, and release of inflammatory cytokines, and increased tumor infiltrating lymphocyte infiltration. So that way you have a synergism here. So the results of the DOE are consistent with the proposed mechanism of action of this PARP inhibitor in combination with immune checkpoint inhibitors. So what it does, especially in the PMMR pathway, so you have olaparib can induce damage to the tumor cell death and lead to tumor cell death, and further immune priming promotes a more robust anti-tumor immunity and more durable benefit. As we saw, there's bringing of more tumor infiltrating lymphocytes, so the tumor is hot, so this combination works well as a maintenance. And then even in the DMMR also, post chemotherapy and durvalumab, blockade of PD-L1 with durvalumab drives prolonged anti-tumor immunity and durable clinical activity in DMMR tumors with limited potential for further. But here also, there's benefit of giving this thing. So let's start with the trial schema. So you have patients with newly diagnosed FIGO stage 3, stage 4 or recurrent endometrial cancer with a known MMR status. We have to stratify them as DMMR or PMMR, and the patients should not have received systemic chemotherapy in the metastatic setting, and they should not have received any PARP inhibitors and immune mediated therapy. And even if they have received adjuvant chemotherapy, it should have been more than 12 months prior. And all histologies are included except sarcomas. And patients were randomized to 1:1, and they were stratified by the proficient or deficient MMR, and whether the patient has a de novo metastatic disease or recurrent metastatic disease, and Asian subpopulation versus rest of the world. And there were three distinct groups. One was the chemotherapy, the Taxol plus carbo plus durvalumab placebo. So it's only the chemotherapy arm. The second arm is chemotherapy plus the durvalumab, which is 1120 milligrams IV Q3 weekly. Just to remind ourselves that durvalumab is available as a 500 milligrams vial as well as a milligrams vial. And the third arm includes chemotherapy plus durvalumab plus the olaparib arm, where you have included the PARP inhibitor as well. And the maintenance could include durvalumab placebo. In the chemotherapy arm, it is both placebo. And in the durvalumab arm, it is durvalumab maintenance with just olaparib placebo. And in the last arm, it is durvalumab plus olaparib, the drugs. And the primary endpoint is the progression-free survival. And in all the three arms, as well as the key secondary endpoints included overall survival and the safety. And the exploratory endpoints included PFS in the durva plus ola versus durva alone, and the subgroup analysis of PFS, including MMR, PD-L1, and the HRR mutated status. And if you see here, the baseline characteristics, Asian subpopulation was in the tune of 28%, and non-Asian was more. It was more of the majority. And apart from that, most importantly, close to 50%, and newly diagnosed as again around 50%. And measurable disease at baseline were more or less. And if you see, most of them, 80% actually, majority was MMR proficient, and 20% were MMR deficient, more or less same in all the three arms. And if you look, it's also very similar to the one which is used for tesliluzumab, and it's close to around 70%, of, and negative in the tune of 25 to 30%, or even 34% in the durva plus olaparib arm. And if you look at the HRR mutations, mutated patients were actually it was only a minority, and non-HR mutations were actually the majority, unknown, close to 1/3 of the patients. And histology, endometrioid was the predominant, followed by serous, and small numbers included other histopathologies. So this is the intent to treatment arm. If you see the PFS and OS, good separation of curves, and Durva plus the olaparib did the best. And if you look at the 18-month, the PFS was 46.3%, followed by 37.8% for the Durva arm, and the arm which had only chemotherapy was 21.7%, which was the least. And if you compare it with the chemo arm, the hazard ratios of the Durva arm as well as the Durva plus olaparib arm was quite good. And if you see here, the overall survival as compared to the chemo arm for Durva plus olaparib arm, it was 0.59, and it was not statistically significant for the Durva arm. So the combination arm of Durva plus olaparib was the best for the overall survival. And looking at the MMR status, 20% of patients, as we discussed, were in the dMMR, and in the dMMR, if you see the combination of Durva plus olaparib, the median PFS for the chemo, it was 7 months. It was not reached for Durva arm, and it was 31.8 months for the Durva plus olaparib arm. And the hazard ratio was not good for the Durva plus olaparib arm. So it goes to say for the dMMR, it was immunotherapy alone which was doing much better, was doing the best. And when you look at the pMMR population, the dMMR plus, the pMMR population, the Durva plus olaparib, if you see the hazard ratio, it was 0.57, which was the best. And it goes to say that at 18 months, it was 42%, and followed by 31.3% for the Durva alone and 20% for the control. So in the pMMR population, Durva plus olaparib did the best. So the pMMR, if you look at the subpopulation of overall response rate and the duration of response, the combination arm of Durva plus olaparib, the overall response rate, objective response was 61.2%, not very different from patients who had Durva alone, was 59.4%. And the median duration of response in the pMMR population was best with the Durva plus olaparib. It was 18.7 months, and it was 10.6 months for the Durva alone plus chemo, and it was 7.6 months for the chemo. And you can see that wide separation in the curves, especially in the pMMR population. But again, looking at the OS, the pMMR, again, it was better. But if you look at the dMMR, the hazard ratios, if you see, it was for the dMMR population, there's nothing much to differentiate between the combination of Durva versus Durva plus olaparib. That is what I'm trying to drive in here. But here, if you see in the pMMR, in the intent to treat population, if you see the Durva plus olaparib, the hazard ratios are much better. And similarly, this is the bi-medial one status. So if the TAP score was more than 1, it was good separation of curves. But if the TAP score was less than 1, if you look at the Durva plus olaparib, there's not much of benefit of giving the combination. So again, going to the PMR subpopulation PFS by biomarker group, and again, score more than 1, it was, and then the TP53 mutations, and also the HR mutated patients. But if you see, the hazard ratios were quite good, but the numbers were not that big. BRCA mutated patients and serous patients did better. This is the combination of Durva plus olaparib. And if you see the safety summary, if you see anemia in the Durva plus olaparib arm, it was quite significant. But what is most important is looking at the grade 3 or more side effects, 67.2% in the combination versus 54.9% in the Durva alone arm. And anemia, which we are worried about, especially for the olaparib, it was close to quarter of the patients as compared to 15.7% for the Durva alone. And not much. So MDS, AML, we have seen that first line, we don't see much of MDS or AML. So that has not been a concern here. So grade 3 or more adverse effects with frequency of at least 5% or more. Again, the Durva plus olaparib, if you see, mainly it is the anemia, and neutropenia. And this is in the maintenance phase. Again, no MDS or AML. And the grade 3 or more adverse effects, of course, were more in the Durva plus olaparib as compared to the Durva alone arm. And this was actually replicated even during the maintenance. So despite triple combination of drugs and increased rates of grade 3 adverse effects, and so there's similar functioning and symptoms comparing the chemotherapy plus durvalumab plus olaparib to chemotherapy alone. So the authors concluded that the DOE study met both primary endpoints, that is both chemo plus durva and chemo plus durva plus olaparib demonstrated significant improvements in the PFS. We're talking about PFS over standard of care, that is only chemo, in the intent to treat population. Interim OS data supported the PFS results, trend towards improvement in OS, but more in the PMMR population for the combination of durva plus olaparib. So chemo plus durvalumab reduced risk of regression, progression or death by 58% versus chemo alone in the DMMR population, with 68% of patients still alive and progression free at 18 months. The combination of chemo plus durva plus olaparib further improved outcomes in the PMMR patients, demonstrating the longest median PFS. We saw that in this patient population with 15 months. That is more than 5.3 months as compared to the standard of care, and reduce the risk of progression or death by 43% versus standard of care, and more than double PFS at 18-month landmark as compared to the standard of care. That is 42% versus 20% at that landmark of 18 months. And further improved outcomes in PD-L1 positive patients, reducing the risk of progression or death by 58% as compared to standard of care, and more than doubled PFS at 18 months landmark. So safety was generally consistent with the known safety signals of each individual agent. So overall, this combination seems to be quite good for patients, especially advanced endometrial malignancy patients who are PMMR and who have got a good TAP score. And so this combination is very good. And if you have a DMMR patient, we would probably just give Durva alone along with chemotherapy instead of giving Durva plus olaparib. This is my take-home message from this. Thank you so much for a patient listening.
Thanks so much, Dr. Vishwanath. So our learnings from DOE trial was in deficient MMR. Also, as per the NCCN guidelines, we would give IO plus chemotherapy, Durva plus chemotherapy, carbo-based backbone, and with Durva maintenance. Whereas when there's proficient MMR, then we are looking for other options. And when we give the combination of Durva with PARP inhibitors, olaparib in this case, then through NF-kappa B and STING pathway, both these pathways, we have seen that the combination performs much better. And of course, this trial brought out the interest in mutations in HRR pathway as well. And then, of course, a long discussion on TAP score with PDL1. So I think with this note, we'll go to the second speaker, who will be talking on integrating immunotherapy and targeted therapy in endometrial cancer. Our speaker for this topic is Dr. Shwetha S. She's a consultant medical oncologist in ESI Rajaji Nagar at Bangalore. Over to you, Dr. Shwetha.
Thank you, ma'am. So are my slides visible?
Yes, ma'am.
Yeah. So firstly, thank you, AstraZeneca, for this opportunity, because we don't usually discuss endometrial carcinomas much. We usually keep on discussing other things. So, but this is also like one of the a very important malignancy. So today's my session would be on integrating immunotherapy and targeted therapy in endometrial cancer. So sir, Dr. Vishwanath sir has made it easy for me by extensively discussing the DOE trial. So systemic therapy for endometrial cancer, so as per the NCCN guidelines, these are all the preferred regimens. So like we all know, paclitaxel carboplatin is our favorite, and we usually start off with that, and only like think of other regimens when there is like there is literally after trying paclitaxel carboplatin. So after chemoradiation, if systemic therapy is preferred at any point of time, usually it is the paclitaxel carboplatin. Pembrolizumab is mentioned in the under category 1 for endometrial carcinomas in NCCN guidelines, although it has limited approval and it's not yet DCGI approved in India. So other options include dostarlimab and durvalumab. All these are category 1 indications. So if we look at the within the brackets here, so pembrolizumab, it's only in non-carcinosarcoma groups because the carcinosarcoma components or histopathology was not included in the trial for pembrolizumab. So at the best, we should always like pray if it should be HER2 positive because it's easy to manage if it's HER2 positive. So carboplatin, paclitaxel, and trastuzumab is the combination for choice if there is a HER2 positive uterine serous carcinomas. So if nothing else can be used, no immunotherapy or targeted therapy can be used, we can always go with paclitaxel carboplatin plus bevacizumab. So these are all the targeted molecules here. Pembrolizumab, dostarlimab, durvalumab are the immunotherapies, trastuzumab an anti-HER2 agent, and bevacizumab the anti-VEGF inhibitor. So that is in the first line metastatic or recurrent setting. Now this is for a recurrent disease. So wherein the preferred regimens include almost similar to the previous slide, paclicarbo, pembrolizumab, dostarlimab or durvalumab and trastuzumab. Or if nothing can be used, paclitaxel and carboplatin alone. So other recommended regimens include paclicarbo and bevacizumab. So biomarker-driven therapy so includes if proficient MMR tumors are there, so then pembrolizumab and lenvatinib. So in TMB high tumors, pembrolizumab alone can be used. So MSI high or DMMR deficient MMR tumors, pembrolizumab or dostarlimab can be used. So other options which we usually keep it for later lines once the disease stops responding to our first line paclicarbo and the patient is still fit for chemotherapy. So we usually go for other chemotherapeutic agents like anthracyclines or topotecan or lenvatinib, docetaxel, ifosfamide and other things. So sometimes if it's a low burden disease, we usually go with hormonal therapies also. So what is important in this is, though NCCN lists almost everything here, so there are only few approved, I mean at least DCGI approved indications here. So only pembrolizumab and lenvatinib is approved in the proficient MMR setting and we cannot use it in the deficient MMR setting. So this is the ESGO-ESTRO-SP guidelines for treatment of recurrent endometrial carcinoma or either unresectable stage 3 or 4 or recurrent endometrial carcinoma with no prior chemotherapy except in the adjuvant setting. So if we look at it, if it is a deficient MMR tumor, usually chemotherapy plus immune checkpoint inhibitor in combination followed by immune checkpoint inhibitor as maintenance therapy. We all usually follow this without giving a second thought. So, but today's discussion is mostly for proficient MMR tumors. So that is the non-MMR deficient tumors. So symptomatic advanced disease or rapidly growing recurrent disease, if it's there, then we usually prefer a chemotherapy. So, and addition of immune checkpoint inhibitor to chemotherapy followed by immune checkpoint inhibitor as maintenance. So there is now another option, that is addition of immune checkpoint inhibitor and immune checkpoint inhibitor plus PARP inhibitor, that is based on the DOE trial. So durvalumab plus olaparib plus chemotherapy could also be used. If chemotherapy is contraindicated, we can go ahead with pembrolizumab lenvatinib. So if immune checkpoint inhibitor or PARP inhibitor are contraindicated and if it's a HER2 positive tumor, so or I would say HER2 positivity can be tested upfront, and if it's a HER2 positive, then preferred regimen would be trastuzumab. If not, go for immune checkpoint inhibitors. So if it's a low-grade ER positive tumor, that is hormone receptor positive tumor, or low volume asymptomatic disease, slowly growing disease, then we can always go for endocrine therapy. So sometimes we tend to use this like as a palliative or metronomic therapy in the later lines, especially if it's the 4th line or 5th line. So we go with tamoxifen or aromatase inhibitors or even medroxyprogesterone acetate. So at any point of time, we can consider some cytoreductive surgery or surgery for the local disease, or even some radiation for control of local disease. So unresectable recurrent disease after first-line platinum-based therapy. So if immune checkpoint inhibitor was used as part of the first-line therapy, so then we usually go for systemic chemotherapy, either platinum combination, adriamycin, or weekly paclitaxel, or endocrine therapy, or a anti-HER2 therapy with trastuzumab and chemotherapy. So if immune checkpoint inhibitor was not used in the previous first-line setting, then we can use immune checkpoint inhibitor in the second-line therapy, and we should always consider a repeat MMR testing. If it's a non-MMR deficient tumor, so usually we go ahead with pembrolizumab plus lenvatinib. Although the trial says pembrolizumab and lenvatinib at a dose of 20 mg per day, but 20 mg is very unlikely to be tolerated in Indian setting, and most of us, I think, we are comfortable in using at a dose of 8 mg or 12 mg OD. So MMR deficient tumors, immune checkpoint monotherapy or pembrolizumab and lenvatinib, both are options. So just to mention, although the approved indication is only for proficient MMR tumors, so we all know, like off-label, we keep using immune therapy and immune checkpoint inhibitors in MSI high setting, because we have been seeing like they do well with other primaries. So combination immune therapy is now established as a second-line standard of care in advanced endometrial cancers. So immunotherapy is changing the second-line advanced endometrial cancer landscape with monotherapy and combination approvals. So if we look at the immunotherapy options here, so ever since in 2015, so when pembrolizumab plus lenvatinib was approved for recurrent endometrial cancers in second-line setting, so we have introduction of dostarlimab, and even like in second line in MSI high and MMR deficient also, pembrolizumab plus lenvatinib came into play. And then there was a full approval by FDA for pembrolizumab plus lenvatinib arm. So this is Keynote 775. This investigated the second-line platinum-based chemotherapy versus pembrolizumab lenvatinib in people with advanced endometrial cancer. So this is a phase 3 randomized open-label multicenter study. So they included advanced stage 3 or 4 recurrent or metastatic endometrial cancer. So previously treated with more than or equal to 1 prior platinum-based regimen in any setting, including the neoadjuvant or adjuvant setting. So available tumor biopsy should be available for MMR status determination. So they stratified based on peers, performance status, geographic region, or history of pelvic radiation. So that look at the dose they have used: lenvatinib at a dose of 20 mg OD. So pembrolizumab 200 mg Q3 weekly, and they have given it for a duration of 24 months or until progressive disease. So they compared it with the treatment of physician choice, that is either paclitaxel or doxorubicin, which was commonly used. Primary endpoints included were PFS, OS, and other secondary endpoints, which are usually standard in oncology trials. So what did Keynote 775 demonstrate? It demonstrated a superior efficacy of second-line pembrolizumab plus lenvatinib versus chemotherapy in people with advanced endometrial cancer 1. So if we look at the PFS in proficient MMR groups, so lenvatinib plus pembro arm showed a 6.7 months PFS compared to 3.8 month PFS in chemotherapy arm with a hazard ratio of 0.60. So in OS also, like final OS in proficient MMR group, so lenvatinib plus pembro arm showed a 18 months overall survival compared to 12.2 months for chemotherapy with a hazard ratio of 0.70. So what I like would say with these curves is like the curves are okay, well separated, and even the hazard ratios are all falling less than 1. But look at the censoring they have done. Like at every point, there is so much of censoring in this study. I don't know, like maybe if we dig deep into the study, maybe the tolerance or something else would explain why there is so much of censoring happening. So this established chemotherapy plus immunotherapy as a first-line standard of choice in advanced metastatic or recurrent endometrial carcinoma. Sorry, this is for the next slide. So the another study, so after pembrolizumab plus lenvatinib was approved for second-line setting as the standard of choice in proficient MMR setting. So then came the NRG-GY018 trial, which evaluated pembrolizumab in first-line setting. This was used in a combination with chemotherapy, that is a platinum-based chemotherapy, paclitaxel and carboplatin, so which is the standard of care first-line drug of choice. So this was the NRG-GY018 study, was the phase 3 randomized double-blind placebo-controlled multi-center study. So wherein they included advanced stages, that is stage 3, 4, 4A and 4B, or recurrent endometrial cancers. No prior chemotherapy was allowed, or if at all they have received adjuvant chemotherapy, there should be a gap of more than 12 months. Prior radiation therapy or hormonal therapy for the treatment of endometrial cancer was allowed. So institutional MMR or IHC testing was done. So what did they do? Pembrolizumab 200 mg plus paclitaxel carboplatin for 6 cycles, followed by pembrolizumab maintenance up to 14 cycles. So versus paclitaxel carboplatin followed by placebo. So primary endpoint included PFS, overall response rate, duration of response, overall survival, and quality of life. So progression-free survival in the MMR deficient population, look at the curves, it's very, very widely separated. So median PFS was not reached in the pembrolizumab plus chemotherapy arm versus 7.6 months in the placebo arm with a hazard ratio of 0.30 and a p-value of less than 0.0001. So PFS in the proficient MMR population, pembrolizumab plus chemotherapy, median PFS of 13.1 compared to 8.7. There is a significant 5 months improvement in median PFS with a hazard ratio of 0.54. So safety in the MMR deficient population, any grade adverse events were like similar, even in it's similar in the proficient MMR group also, although the grade 3 or more adverse events were a little higher in the pembrolizumab plus chemotherapy arm. So this is Ruby part 1, which investigated first-line dostarlimab plus or minus platinum-based chemotherapy plus or minus dostarlimab maintenance. So in people with recurrent or primary advanced stage 3-4 endometrial cancer. So now we have looked into pembrolizumab as first-line therapy in advanced endometrial cancer. So the another immunotherapy which has a role is dostarlimab. So dostarlimab was investigated in the Ruby part 1 trial. So what did they include? Advanced stage 3 or 4 or recurrent endometrial cancer with poor potential for cure by surgery or radiotherapy, and no prior chemotherapy, or if at all they have used chemotherapy, it should be at least a 6 months gap. So they gave dostarlimab along with paclitaxel carboplatin every 3 weekly, followed by dostarlimab maintenance. So dostarlimab was given for 3 years as the maintenance. So pembrolizumab was given for 2 years as maintenance phase. So they compared it with placebo plus paclicarbo was followed by placebo maintenance. So primary endpoints were PFS and OS. Secondary endpoints were PFS, PFS2, overall response rate, duration of response, disease control rate, and other things. They stratified based on microsatellite status, disease status, stage 3 or 4 versus recurrent, prior pelvic radiotherapy. So at an interim analysis, this Ruby part 1, it met its co-primary endpoint if improved PFS with improved PFS. So PFS in the intention to treat population was 36.1 months in the dostarlimab group versus 18 months in the placebo group. PFS in MMR deficient or MSI high population was 61 months in the dostarlimab group versus 15.7 months in the placebo group. So all these drugs are actually FDA approved for use in these settings. So in the overall study population, discontinuation due to treatment emergent adverse events occurred in 17.4% in the dostarlimab group compared to 9.3% in the placebo group. So if we look into all these studies, they all show a higher rate of adverse events with immunotherapy plus chemotherapy combination, which is usually expected, but I think it's all well manageable now. So there, it also showed a statistically significant overall survival benefit in overall population. So if we look at 2-year overall survival, it was 70% versus 54%. 3-year overall survival was 54% versus 42%. So in the MMR proficient group, 1-year overall survival was 54% versus 31%. So basically, it had a statistically significant overall survival in the overall population also, in deficient MMR population also, and proficient MMR population also. But dostarlimab is not yet available in India. So, but they're eagerly waiting to launch it in India soon. So we should at least know what it does. So dostarlimab plus paclicarbo, it showed a statistically significant and clinically relevant overall survival benefit in the overall population compared with paclicarbo alone. So survival difference was seen both in deficient MMR and also proficient MMR group. Next study is NGOT study. So they included patients of, so this is the Ruby part 2 study. So they included patients of stage 3 or 4 disease or first recurrent endometrial carcinoma. So all histologies except sarcomas were included. So and they should be naive to PARP inhibitor therapy. So they used dostarlimab in combination with niraparib as maintenance. That is a PARP inhibitor niraparib, which was used as a maintenance. So that is the only difference between, I mean, this is the Ruby part 2 study. So in part 1, they have just compared the dostarlimab for dostarlimab chemotherapy followed by dostarlimab maintenance. So versus placebo, chemotherapy versus placebo maintenance. But in the part 2, they have compared dostarlimab chemotherapy followed by dostarlimab plus niraparib maintenance versus placebo maintenance. So primary endpoint was PFS. So if we compare both the studies, that is DUO-E and Ruby part 2 study, so intention to treat population, median PFS was almost similar, 15.1 months with durva-ola plus chemotherapy compared to dostarlimab plus niraparib plus chemotherapy, 14.5 months. The hazard ratio was also somewhat similar, hazard ratio of 0.55 versus hazard ratio of 0.60. In deficient MMR group, 31.8 months in the durva-olaparib, so with hazard ratio of 0.41, but it was not separately evaluated in the dostarlimab and niraparib arm, but the hazard ratio was found to be 0.48. So in the proficient MMR group, it was 15 months compared to 14.3 months, as the hazard ratio of 0.57 and hazard ratio of 0.63. So hazard ratio is slightly better with the durvalumab and olaparib compared to dostarlimab and niraparib. So, and I think now we are all very much accustomed to using olaparib in multiple other settings, and so durvalumab also. So maybe like when dostarlimab comes into the market, so we'll be still inclined to use durvalumab and olaparib. So deficient MMR, DUO-E, Ruby part 1, and NRG GT018 and ATTEND trial. ATTEND is one study where they have tried atezolizumab for the atezolizumab for endometrial cancers, that is advanced endometrial cancers. So although like initially it got approval, nowadays like atezolizumab is out of question. So in DUO-E, if we look at the standard of care plus durva arm, standard of care plus durva plus olaparib arm were compared. So median PFS was 7 months with standard of care choice, that is chemotherapy alone. So versus not reached with durvalumab arm, and 31.8 months for chemotherapy plus durvalumab plus olaparib arm with a hazard ratio of 0.41. So this is the overall data. So sorry, this is for the deficient MMR data. So if we look at the hazard ratio for durva plus olaparib plus chemotherapy arm, it was 0.97, that is 0.49 to 1.98 is the confidence interval here. That means it could be hazardous in using for some patients in at least deficient MMR setting. That is why it has not got an approval for use in deficient MMR setting, and durvalumab plus olaparib plus chemotherapy is now currently approved for use in proficient MMR setting. So coming to Ruby part 1, where dostarlimab was used. So the hazard ratio was around 0.28 in the deficient MMR setting. So for pembrolizumab plus this thing also, the hazard ratio was 0.30. So the median PFS was not reached in both the arms. So proficient MMR, in proficient MMR setting, if we compare, so the chemotherapy plus durvalumab plus olaparib arm has got a PFS of around 42%. So hazard ratio 0.76 with 0.59 to 0.99. So hazard ratio versus standard of care, it was 0.57, that is 0.44 to 0.73. So if we look at the durvalumab plus chemotherapy compared to standard of choice, that is chemotherapy alone, so the hazard ratio was once again very high, that is 0.77, with a confidence interval almost going to be 1. So that is why we have not got a good evidence for durvalumab alone, at least at present. But however, durvalumab plus olaparib did do very well compared to standard chemotherapy arm, and it is approved also for this in this particular setting. So when we look at the Ruby part 1 study, that is dostarlimab versus standard chemotherapy, so the hazard ratio was 0.76 and a little on the higher side. So with a PFS of around 28.4 months. So in the proficient MMR arm. So when we look at the pembrolizumab, the median, the PFS rate was not reported, but the hazard ratio was 0.54. So although the data was convincing, if we look at the PFS rates, so the highest is for durvalumab plus olaparib plus chemotherapy in proficient MMR group. So at least this should encourage us to use durvalumab plus olaparib plus chemotherapy in the proficient MMR group in the first line setting. So I know like it is a little confusing with so many immunotherapy options, and whether it is deficient MMR, proficient MMR, and other things. So in general, if it's a proficient MMR group, so and if it's a carcinosarcoma, so without any second thought, we can always go for durvalumab plus olaparib plus chemotherapy, because pembrolizumab arm, pembrolizumab study, it never included carcinosarcoma patients. If you look at the first red rectangle here, so in the NRG GY018 trial, carcinosarcoma patients were 0. They were not included in the study, and we get a pretty few, good number of carcinosarcoma patients also. So it's not always the endometrioid carcinoma which we usually see. So in carcinosarcoma, there is no evidence for using pembrolizumab. So even like NCCN guidelines also, they usually exclude pembrolizumab for use in carcinosarcoma. They have the category 1 recommendation only for non-carcinosarcoma patients. So when we look at the progression-free survival, it was more than 6 months for Ruby trial. So more than 12 months in the pembrolizumab, and rest also more than 6 months data. So, and the duration of maintenance was 3 years for dostarlimab, 2 years for pembrolizumab, and until progression or toxicity for atezolizumab and durvalumab. Okay, so that was my last slide. So I hope I am just clear with the message. In proficient MMR in non-carcinosarcoma, so it's always, in carcinosarcoma group, it's always like pembrolizumab cannot be used in carcinosarcoma variant, at least according to labels. So we can always choose the durvalumab plus olaparib plus chemotherapy in this setting. Thank you.
Thanks so much, Dr. Shwetha. It was actually, a complicated trial set, but you managed it very seamlessly and very nice summary in the end, including what are the differences and what are the uses where. And the next topic is diagnosis and diagnostics in endometrial cancer. This will be taken up by Professor Dr. Shobha, who's the head of the Department of Gynae Oncology at Kidwai Memorial Institute of Oncology at Bangalore. Over to you, ma'am.
Thank you so much, Dr. Niti. Yeah, Is my slide see my PPT?
Not yet.
No, ma'am.
Yeah, now?
Ma'am, if
No,
you
ma'am.
will come to your Zoom screen, you can press on share screen. And then, ma'am, you can select the PPT tab.
1 second, 1 second. Yeah, share. I did that.
Yes, ma'am. Then you can just click on screen and then share.
It's not opening.
Ma'am, if it's okay
with
with
your permission, can we play from our end?
Yeah, you can. I made some changes.
ma'am, I'll just try guiding you once more. Ma'am, are you at your Zoom screen?
1 second. Yeah.
Ma'am, at the bottom center, you can click on share screen.
Yes.
Ma'am, you'll have a tab open in front of you. If you can click on screen.
There's no screen here. Box, Microsoft, Google
At the bottom,
Drive.
can you see your PPT, ma'am? If you can just click on your presentation and just share.
No, presentation is not seen. Yeah, now it is seen here. On my screen, presentation is there, but not able to share.
Ma'am, in the Zoom, if
Mhm.
you press Alt S,
Yeah, share and screen is there.
yes, ma'am.
I press
And
that.
yes, ma'am. Now there will be a tab
Okay, I think
where you,
I got it.
yes, ma'am.
Yeah, sorry. Okay, fine. Yeah, I thought, I think we are going in a reverse order. So this is the basic diagnostics where it's important for accurate diagnosis and then, to guide for personalized management of endometrial CA. So diagnostics includes combination of clinical evaluation, imaging, pathological studies, and molecular studies. So as all of us know, 80% of the endometrial cancer come in early stage. So accurate diagnosis is very important. So that can be done with our clinical examination, basic transvaginal scan, which will help us to know whether endometrial biopsy is required or not. And then if biopsy comes as positive for malignancy, then an MRI in apparently early stage. PET CT is primarily we do most of the time in type 2 endometrioid carcinoma, or if we feel it is locally advanced. So yeah, clinically, 80% of them present with abnormal uterine bleeding, and then pelvic pain and discharge in some. And then risk factors, of course, all of us know that obesity, hypertension, diabetes, unopposed estrogen use, chronic PCOS, anevolution, and for strong family history, which includes Lynch syndrome majorly. So with our endometrial people biopsy, we get the histopathological diagnosis in 99.5%. Only less than 1%, sometimes it is not diagnosed there when we have to do a histoscopy guided biopsy. So the biopsy will tell us the type of tumor, whether it is endometrioid or non-endometrioid, then the grade of the tumor, grade 1 and 2, which is under low grade now, and grade 3 is high grade. Then yes, some of the pathologists can tell about the LVSI. If known, it is well and good preoperatively. And then, of course, if IHC can be done, molecular profiling, if it's done, that also will help us to plan further management. So now the TCGA classification, what the previous speakers were talking about, why is it needed? Histology-based classification lacked the reproducibility and prognostic accuracy, and the molecular diversity was not captured in the type 1 and type 2 division. Then there was a lot of high inter-observer variability in grading. So what we thought grade 1 preoperatively turned out to be grade 3 postoperatively. So the variability was there. And then TCGA aimed to refine the classification using genomic, transcriptomic, and proteomic data. So this will guide us for personalized precision management postoperatively. So with that, yes, this is a repetitive slide. So 4 TCGA molecular subtypes, the pole ultra mutated, which is a very good kind of tumor. And then second one is MSI hypermutated. This is intermediate variety. And then we have copy number low and high. Copy number high is P53 mutated ones, which are prognostically poor varieties. And we have copy number low, which doesn't belong to any low or high grade. So that is in the intermediate one. So non-specific molecular profile tumors. So what is the clinical implication of this TCGA classification? So we use the molecular classification for risk stratification and treatment decisions now. So present standard guidelines, we use molecular typing for stratifying the final, after the surgical pathological staging, we include and to stratify them into whether it is low, intermediate or high risk. And then we decide on the adjuvant therapy. So we incorporate pole, MSI, P53 and copy number data, then align the treatment with the molecular subtype, so much of immunotherapy we heard of. So we're all to give immunotherapy, especially if MSI, and then we can de-escalate if it is a pole mutated cancer. So this definitely enables precision medicine and improved trial designs too. So this is the table where it says that now you integrate the molecular markers and prognostic risk groups, divide them into prognostic risk groups, and accordingly advise them the adjuvant radiation or chemotherapy or immunotherapy. So coming to the principles of molecular analysis. So we do first the thing what we do is pole sequencing. So pole sequencing, if it is pole mutated, then we divide them into the ultra pole mutated group. If there is no pole, then we do MMR on IHC or MSI testing with PCR or NGS. So if MMR is aberrant, then we classify them as deficient MMR or MSI-H. Then if MMR is normal, then we go ahead to do P53 in IHC. If P53 is mutated, then we put it as P53 aberrant, that is high copy number. Then if it is a normal or wild type of P53, then we put it in the group of NSMP, a non-specific molecular profile group. So what is this MMR, what we are talking about so much, right? So we know that whenever there is a breakage in the DNA, there is an automatic repair mechanism is there. So different type of breakages like single strand break, double strand breakage, or there might be cross links, base mismatch repair. Accordingly, there are repair mechanism also. So single strand usually it repairs by base excision repair, and double-stranded they repair by homologous recombination or non-homologous end joining. So if it is a base mismatch repair is breakage is there, then the repair is through this mismatch mediated repair, that MMR. So this mechanism exists in the cells to correct these repairs, hence the name mismatch repair. So mismatch repair system includes mainly 4 proteins, that is MLH1, MSH2, MSH6, PMS2 and others. So these MMR proteins, they work in pairs to repair DNA damage. So when do we call this as a proficient MMR? It is whenever there is a functional MMR system, that is when there is no deficiency or there is no defect. Or we call it as deficient MMR whenever there is loss in expression of these proteins, or whenever there is mutations leading to the inability of the cells to repair the DNA defects. That is deficient MMR. So most common one are the loss in the expression, which is detected by IHC, that is deficient MMR. So what is MSI? So microsatellites are repeating sequences in a DNA, and it is unique to an individual, just like a DNA fingerprints. And microsatellite instability, it can be seen as alternate size repetitive DNA sequences, and it is seen in tumor DNA, not in normal DNA, right? So MS is in normal DNA, whereas MSI, that is instability, is in abnormal DNA, in tumor DNA. So microsatellites from tumor and paired normal tissue, they're analyzed simultaneously by PCR or NGS. So as I said, MSI can be seen as alternate sized repetitive DNA sequences, what you see here in this table, which is present in tumor DNA but absent in normal DNA. So when it is defect is there, we call it as MSI high. If it is normal, we call it as microsatellite stable or MSI low. So this term should be accurately done. So what is the relationship between deficient MMR and MSI? So in proficient MMR, there is no DNA replication errors. So it is stable, MSI stable or MSI low, right? Whereas in deficient MMR, there is DNA replication errors. So we put them in MSIH. So MMR and MSI are two sides of the same coin, different ways of measuring. One you're measuring in IHC, the other one you're measuring in PCR or in NGS. The same phenomena, but they're not the same thing actually. So why we have to test for this MMR and MSI? One is to know the susceptibility to immunotherapy. We saw so much of targeted therapy, immunotherapy coming up in endometrial CA management, improving the PFS, maybe improving in with showing the improvement in the OS also. So to know this, definitely we need to do MMR or MSI. Then deficient MMR phenotype leads to increased sensitivity of immunotherapy. Histomolecular classification of endometrial carcinoma. Along with this, now TCGA classification has to be done, says all the guidelines, be it ESGO, ESTRO, FIGO or NCCN. They say MMR testing is a must, is standard in all diagnosed CA endometrium. And also you have to identify hypermutated deficient MMR or MSI in endometrial carcinoma group with important management and prognostic implications. Also, this testing, MSI testing, will help us to screen this Lynch syndrome people, so which is an inherited disorder, and where they'll have germline mutations in MMR genes, which are associated with MSI high tumor status in tumors. So this syndrome is associated with elevated risk of developing endometrial cancer, colorectal cancer, stomach, urothelial, and other ovarian cancer too. So this is a standard MSI testing, MMR testing is standard now in all diagnosed endometrial cancer. So this is the PROMISE molecular classifier. So here also it's almost similar to what we did here. Here, this one, first they do the MMR testing they do. If it is deficient, they don't do anything. If it is intact, then you'll have to do a pole mutation. If pole mutated, if it is there, then we diagnose them into pole. If it is a wild type, then do P53. Almost it's in the reverse order. So this is the PROMISE thing. So accordingly, the fourth molecular classification tells us whether it is a good what is a prognostic one or a poorer prognostic one. So yeah, I think it will be repetition of this one. Then how to test the deficient MMR testing modalities? What are the different various? As I said, IHC, PCR, NGS. IHC, there will be loss of expressions of the 4 key proteins, any of the 4 key proteins which I mentioned previously. The advantage of IHC is that it is widely available. It can suggest which protein is affected, and it guides whether germline versus somatic workup to be done. And of course, if we can do it pre-operatively also, so that also helps us to personalize the treatment. Whereas MSI testing can be done either with PCR or NGS. Then we express it as MSI high or low. Both are complementary, both IHC and this one, but not identical. What is the concordance in them? Almost up to 97% it is concordant. Only in 3 to 4% it is discordant, especially whenever there is a cancer treated. I mean, if in the setting of neoadjuvant chemotherapy, there might be some discordant, or there might be some discordant whenever there is a fixation artifacts or unusual staining patterns or insufficient sensitivity of MSI testing can be there. So IHC proficient MMR reading obtained in MSI-H tumors example. Here also, whenever there is due to LOF mutations with preserved protein expression, there might be some kind of discordance. Yeah, this is the same thing what I said. So don't either PCR, NGS or IHC. Here also we test for HER2 molecule, then expression, and then PD-L1 expression also, which will guide us for further immunotherapy and targeted therapy. What about MSI testing? So either PCR or NGS. PCR, we get the report within 10 hours, whereas NGS requires 2 to 3 weeks minimum. And then limitations are only PCR characterizes MSI. It requires molecular training, whereas NGS, large sample requirement is required. There's a lack of standardization globally. It requires advanced molecular training, technical issues. So it might lead to misclassification or false results. Highly stringent DNA quality requirements are there. So coming to the testing next for Lynch syndrome. So as I said, universal testing of endometrial cancers with MMR protein is recommended now. So MSI testing should be done only when the IHC reports are equivocal. If there is MLH1 loss, then further it should be evaluated for promoter methylation to assess an epigenetic mechanism. Then further genetic counseling, molecular analysis, and testing for all MMR abnormalities is recommended. For those who have strong family history of endometrial CA or colorectal cancer, genetic counseling and testing are recommended regardless of MMR or MLH1 promoter methylation results. These are the NCCN guidelines. So yeah, so this mismatch repair expressions by IHC. So if there are, yeah, it's quite, so MLH positive mutations may not result in protein loss. Then in rare cases, MLH1 protein could not be present but non-functional. Then we'll have, whenever we observe MLH1 loss, we'll have to do MLH1 methylation analysis. If methylation analysis, then it is somatic MLH1 loss, and we'll categorize as MSI. If there is MLH1 unmethylation, then we'll have to perform germline mutation testing. If there are pathologic mutation, then we have to consider as Lynch syndrome and then screen them for other cancers. So this one, I wanted to put this. Now recommendations have added along with whatever recommendations are there. We'll have to do, what is this I wanted to add? Yeah, in NSMP, that is a non-specific molecular profile, IHC will be done for estrogen receptors. So if estrogen receptors are positive, we'll grade them accordingly. If it is a low grade, we'll put it as NSMP low grade and estrogen receptor positive. High grade, then we'll put it as NSMP high grade estrogen receptor negative. So this is one addition along with our molecular markers. So this is briefly that to summarize the whole thing, precision, I mean, as we are going towards a precision treatment, initial diagnosis should be highly accurate so that the personalized management will be optimal. Thank you.
Thanks so much, Dr. Shobha. Rightly told about PROMIS molecular classifier. Of course, the methods of MSI testing, which could be either IHC or PCR or NGS. And of course, I mean, when MLH1 promoter methylation needs to be tested. So thanks so much, ma'am. We'll move on to our case-based discussion on endometrial cancer. This will be moderated by Dr. Sai Vivek, who's a consultant medical oncologist and hemato-oncologist at Aster CMI Hospital in Bangalore. We have a power-packed panel, which is Dr. Supreet RN, consultant medical oncologist from Sri Shankara Cancer Hospital, Dr. Ravi Tippaswamy, who's a medical oncologist from HCG, Dr. Srivalli, consultant medical oncologist from Manipal Hospital, Bangalore, and Dr. Rachan Shetty, a medical oncologist from AJ Hospital in Bangalore. So over to you, Sai.
Thank you, ma'am. Good evening, everyone. And I would like to thank AstraZeneca for this opportunity. At the outset, I would like to request Shobha madam to just be around for 5 to 10 minutes to clear our doubts on the surgical management. The slides have been shared by AstraZeneca. So without wasting any time, I would start off the discussion. I have four eminent panelists with us. So we'll start off with a case. So, 63-year-old lady presented with postmenopausal bleeding since 2 months, that is April 2022. Ultrasound was done, which showed thickened endometrium. MRI was then done, which showed thickening of endometrial mucosa at fundus, involves less than half of myometrial thickness, but myometrium was definitely involved. A hysteroscopic biopsy was moderately differentiated adenocarcinoma, high nuclear grade. She underwent hysterectomy later that month on 18th of April 2022. So the histopathology was a 3.5 centimeter tumor located at the uterine fundus, involves the anterior and posterior wall, involves more than half of the myometrial thickness. Right and pelvic lymph nodes, right and left pelvic lymph nodes were dissected, 0 bar 21 lymph nodes involved, no LVSI, grade 1 FIGO staging T1B N0 M0. So I think I would like to start off with Shobha madam to enlighten us about the different types of surgery used right now. Is there a role of PLND or we just do sentinel for them? When do we go ahead and do para-aortic nodal dissection? And when do we do omentectomy? If madam is there, I'd like to take her opinion on this.
I'm here. Thank you. Yeah, as you said, now surgery types of surgery here, minimally invasive surgery has become standard globally. So for all diagnosed CA endometrium, first option we do give MIS, keeping the obesity in mind and other comorbidities, and it is seen in all types, whether it is high risk or low risk. It can be safely done. So role of PLND, yes, it's as a part of surgical pathological staging, it is still involved, PLND, but now with sentinel lymph node becoming more popular, yes, the accuracy is good there, but the centers where it is validated only we can practice. Otherwise, I think not everyone just we can do. So we should have a proper, now with the robotic system being there, I think with ICG, accuracy has become pretty good. And barring the side effects of complete systemic lymphadenectomy, especially the lymphedema, I think sentinel lymph node has got a role in the C endometrium management. Para-aortic, here we still practice para-aortic nodal dissection in high-risk groups. High risk, when I say, it means a grade 3 or a poorly differentiated carcinoma, when the myometrial invasion is more than 50% or going up to the serosa, or if the adnexa are involved, one, or if the suspicious pelvic lymph nodes are there, then we still go one station above to remove the para-aortic and do sampling. And then up to what extent, yes, now as I said here, if she's usually up to intramesenteric, up to IMA standard we'll go, but intrarenal also, I think if the tumor low volume is occupying the whole of cavity and adnexa are involved, then more chances of para-aortic positivity is quite there. So up to renal vein is what is recommended. So then staging omentectomy, yes, part of surgical procedure we do in serous, uterine serous, papillary serous, which behaves like ovarian cancer. Apart from that, clear cell, no, not indeed really indicated. I think only in UPSC. Then peritoneal washings, it is in the textbooks, they mention peritoneal washings as a part of surgical staging, but not much of it doesn't change our adjuvant therapy if it comes as positive also. So it is just like a independent prognostic poor marker, that's all. But it does not upstage the disease if it's going to be positive.
Thank you, ma'am, for clarifying that in a very simplified way. So moving on, so what are the factors that guide us in the treatment overall, I would like to first go to Ravi sir. Sir, what do you look at when you get a histopathology in such a case who has undergone surgery elsewhere or at the same hospital? What do your eyes look for in the first three factors if you have to simplify it?
Yeah, I think mainly apart from the standard TNM, that is the depth of invasion, grade of the tumor, and LVI, PNI. Histopathology plays a very important role. I think discussion with the pathologist, especially in the early stage, if it is metastatic and all, probably the discussion, though it is important, but in early stage, I think without discussing with the pathologist, it's very difficult to take the decision. And nowadays, I think by default, we are doing the IHC or NGS for the prognostic markers like POL, P53, MMR. Then in a slightly advanced stage, we do HER2 also, or comprehensive gene panel, and lymph nodes and all. It comes at the later. I think these are the important in early stage, especially grade of the tumor, LVI, PNI, and the prognostic markers.
Yes, sir. I think well noted, sir. Dr. Rachin, anything else from your side that you would like to add to what Ravi sir just enumerated?
No, actually, molecular testing, I mean, if they can afford, will send for most patients. Not for stage one, though. Not for stage one.
Not for stage one, absolutely. So I think, yeah, I think discussion with the pathologist and the surgeon plays a very important role, especially in endometrial cancer, because a lot of treatment decisions and risk stratification are based on those particular factors. So as just to summarize, the histology first, then we need to know whether myometrium is involved or not. That is the depth of invasion, the grade of the tumor, LVSI, followed by whether there are the molecular markers would be the top five in terms of what we look at in any histopathological report of an operated CA endometrium. So briefly, this is just to keep it out there that this is the risk stratification that we are following. The newer one has been released, but I think most of us are still following this. Dr. Srivalli, are you still following this risk stratification, or have you moved on to the 2024 one?
So actually, I think we are just keeping this only as of now, and then looking into the mutations and then upstaging them if they are P53 positive.
Yeah, I think most of the trials were based on this. I think only with time we'll be able to move on to the next one. Shobha, madam, are you also following this, the older one, or any insights on what is the benefit of the newer risk stratification?
No, we are also following the same one. And since most of our patients are under free scheme and we still don't have the option for targeted or newer treatment. So I think, yes, we are, and we don't have a testing for all as such. So we are still working on that. So
I think, yeah, the major point where pole comes to play is in stage 2 and stage 3, where they get downstage to low.
yes, down to low risk. Yeah.
Yes.
So
So
we
that
can
is,
avoid chemotherapy.
we can avoid chemotherapy and I think even radiation in certain cancers where they become low risk where no other treatment is necessary. So this is our low risk and intermediate risk. For low risk, that is no myometrial invasion, grade 1A. Stage 1A, there is no adjuvant treatment necessary. And these are the ESMO guidelines. I wouldn't spend too much time on this. So coming back to our patient, so she fell into intermediate risk based on grade 1 and 2 myometrial invasion present. So she underwent brachytherapy with iridium, 7 gray in 3 fractions. She was on follow-up till May 2023. And in July 2023, we'll see what happened to her. So we do not have a radiation oncologist with us. I would like to give this question to Dr. Supreet. What is the protocol that you follow at your institute for, I think, an intermediate risk as such, like this patient? What is the type of radiation you choose and role of proton? I would just leave it there. Dr. Supreet?
Yes, sir. I think it would be external beam radiation followed by brachytherapy. I honestly don't know the intricacies of the dosing and what nuclide they use. But yeah, proton, I have no experience.
I think we'll leave it to our radiation oncology colleagues. So, would you want to give EBRT for this patient? I'm talking about this particular patient. It's intermediate.
No, sir.
Yeah.
No.
So it's only brachytherapy for this patient. So she received adequate treatment in the upfront setting. And let's say we had to give an EBRT, what would be the preferred regimen that you would be choosing? Are you giving right now concurrent, and if you're giving concurrent, what are you using?
So we follow paclitaxel carboplatin 4 cycles followed by CTRT with cisplatin, Liportec 3-1. But in the other order, like they did CTRT followed by systemic, but
okay,
I do this.
So Ravi sir, any other insights into this when you're talking about CTRT and adjuvant treatment? Is there for all patients you're giving concurrent, or some patients only radiation followed by adjuvant?
Yeah, I think what Dr. Suprit told that we are following, many of the time concurrent chemo radiation we avoid. It's only paclitaxel carboplatin and then followed by radiation, or we can sandwich also. Yeah.
Sandwich also, okay.
In
So
our institute also we follow sandwich therapy only. I think that is quite well tolerated by the patients.
yes, ma'am. I think 2 followed by radiation, followed by 2 chemos, madam.
Yes.
Okay, yeah. Dr. Rachan, anything else from Mangalore? Any other difference in opinion in terms of CTRT?
No, none at all.
None at all. Okay, so moving
I
on.
just have a small question to all of the panelists. In high-grade serous carcinoma, how are we looking at the role of radiation, especially if it is stage 3? There was this NRG trial which said that adding radiation did not add to the benefit. Is it really true?
Yeah, even we keep discussing the same thing with our radiation colleagues. So do we have to really send them for radiotherapy? But what they say is, see, you're giving in the intention to cure. So the maximum cure rate will be when you have a local control also. So they say adding radiation, yes, more of local control also will be there. So we are still practicing both chemo and radiation. Only maybe fragile patients or elderly high patients where they cannot tolerate, we are just giving chemotherapy in this subgroup.
Yeah, I think we are doing the same also. We are at this point to control the local recurrences, we are doing both concurrently. We are doing chemo and radiation. Dr. Srivali, any opinion of yours in this matter?
So same thing, sir. I think here maybe instead of 4 cycles, I would be inclined to give a total of 6 cycles and then send for radiation only.
And then radiation. But is there any data backing 6 cycles?
No, so as in it's just that we have discussed with our radiation oncologist, 4 to 6, they say the moment you see high grade, they're like, okay, finish off all 6 and then send for radiation because I don't use cisplatin concurrence.
Okay. I think, yeah, very minimally we are using it. Patients sometimes do not end up tolerating it. So back to our case, this patient was treated adequately in 2022. And let's say in 2024, she had a relapse. It was an FDG of it, conglomerate and discrete right-sided common iliac. External and internal iliac lymph nodes are noted, largest 3 centimeters. And intraperitoneal soft tissue density lesion is noted in the right iliac fossa, measuring 8 into 7 millimeter in size, which was suggestive of a relapse, as we can see in this particular PET scan images. So, Dr. Supreet, what do you test for at diagnosis? What do you test for after relapse? Is there any change, or all the markers are available with you when there is a relapse?
So at relapse, I would do the 3 molecular tests that were discussed earlier, poly, MMR, and P53. Besides that, HER2 is one more thing which I would be doing. At diagnosis again, all these tests I would. Sorry. I think sorry. At diagnosis, whenever there is an adjuvant treatment that is planned, I would be doing all these 3 molecular tests besides HER2. And at relapse, again, it is MMR and HER2 which play the role.
Okay, there is some data for stage 3 to give trastuzumab, sometimes even in the adjuvant setting, as was seen, as was shown by our previous speakers. So I think HER2 at diagnosis also is now becoming an important biomarker.
Now
So
they've added, I think, in the ESMO guidelines.
yes, madam. Yes, madam. So Ravi sir, do you actually routinely do comprehensive genomic profiling or any other panel at relapse, or these markers are sufficient to plan the next treatment?
Yeah, generally these markers are sufficient, but nowadays we are moving to CGPs as a protocol, hospital-based protocol, just to see. But more or less, we don't see any other mutations apart from the standard till now.
Okay. So, Dr. Srivalli, for this particular patient, the patient has a relapse, and you have the data with you. Let's say it is MMR proficient, HER2 negative, and we know POL is also not mutated. What would be your first line of treatment for this particular patient?
So proficient MMR we have got here, sir. So definitely partly carbo chemotherapy with targeted now with the new data of durvalumab. I would like to tell them about that. And otherwise, I would add bevacizumab.
Durvalumab alone, or
No, then olaparib as well. Yeah.
are you
But
convinced with the data that you have, except the financial toxicity?
yes, so that's the first point. It's a financially toxic regimen because counseling our patients for Durva itself is quite difficult. I think Ola now we have generics.
Yeah.
But yes, sir, it did have a PFS and an OS benefit as well. I think we might start, if we start using, we will see the responses. That's what I feel, sir.
Yeah, I think Dr. Rachan, any difference there? Would you want to keep immunotherapy for the second line in such a setting, or go ahead and hit it hardest in the first line setting?
I mean, in oncology, use the best drugs upfront. If finances are not an issue, do PGT for all patients and use the best drugs upfront. But most of the time, in at least in Bangalore, 99% of the patients we are not able to do all the things. So if it is endometrial type of endometrial CA, we other than the molecular markers, we look for ER status.
Correct.
They tend to do well, and probably after give chemo, put them on letrozole maintenance. So that's what I.
Okay. So now comes the bouncer in this particular case. I didn't understand it myself. So the biopsy of the lymph node again was suggestive of a high-grade serous adenocarcinoma, not the endometrioid grade 1 or grade 2 that we actually saw at the time of surgery. Ravi sir, what is your take on this? I mean, I know it's a hypothetical case, but have you seen cases where the histology changes?
Generally, no, we have not seen change of histology.
Yeah, so I think such a rare case, yes, chemotherapy followed by with plus or minus immunotherapy and olaparib probably would cover everything. Shobha madam, do you come across such scenarios?
No, usually no.
Yeah.
Sometimes well differentiated can become poorly differentiated, but histology wise, definitely I'm not
Definitely
thinking that.
no. I
Not in
think
endometrial cancer.
yes. So we'll take it as a relapse of endometrial cancer. We'll disregard that particular report as of now. So we did discuss about what molecular markers that we would be doing at diagnosis and at relapse, and all of us are in agreement in terms of when do we do it. So this has been spoken about before. So we have to ideally divide all our patients into one of these molecular subgroups. And this is the data from TCGA. We know that the MSI high group and the NSMP constitute 25 and 40% respectively. The rest of the groups, which is the POL mutated or P53, constitute the rest of the cases of endometrial cancer. So on IHC in this particular patient, again, we come to know that P53 is mutated. I think it's following with this high-grade serous. So a histology review of the initial surgery again would definitely be warranted. ERPR is positive, which is again going more in favor of the endometrioid. HER2 is negative, MSI stable. So these are all things which have been discussed before, the 4 molecular subgroup. And Madam has very beautifully told us about how do you test for Lynch syndrome. So I would not be going for that. So what is the current line of management in the deficient and proficient MMR in advanced endometrial cancer patient? Dr. Supreet? So let's say first talk about deficient, and then you can tell us proficient in terms of what you would use in the patients.
So in deficient MMR, single agent Pembro is fine in a patient who has got borderline performance status, or else it would be chemo plus Pembro. In proficient MMR, again, chemo plus Pembro, but obviously I would explain to the patient that the benefit with immunotherapy may not be as dramatic as it is with deficient MMR, and maintenance with Pembro. That has been my preferred choice of treatment.
So this patient has, I would somehow call it not a disseminated metastasis. She has lymph nodes, and even the peritoneal deposit is around 3 millimeters. any role of consolidating the treatment? Ravi sir, would you want to give EBRT? She has received only brachytherapy. After few cycles, would you want to consolidate or a second surgery? What is your take on it, sir?
Yeah, I think in a oligometastasis, if the patient does well with our systemic treatment, after say 4 or 6 cycles, I would like to consider with the EBRT. Surgery, I'm not keen, but EBRT definitely.
Okay. Dr. Rachan, would you do the same thing for both deficient and proficient MMR, or deficient, you're more comfortable in just letting immunotherapy take care?
So deficient, I think I would give immunotherapy. See, regarding surgery, I mean, secondary, because it's involving lymph node dissection and post lymph node dissection, lymphedema and all those things has to be discussed. Even if you do RT also, it will be there.
Okay. Okay. I think we'll take Madam's opinion on this. Madam, how often do such patients come for a second surgery? And what is your take on it?
Yeah, see, endometrium being relatively a good prognostic, this one cancer, there when we get recurrence, also it is most of the time it is localized. So peritoneal carcinomatosis or with presenting with ascites and all are very quite rare. So secondary cytoreduction, yes, we do whenever the performance status is good and isolated mets in maybe paraiotic area or any lymph node mets are there, which we can remove completely. So optimally, we have to remove that, debulk it. Then definitely there is a role of secondary cytoreduction. But when there is a peritoneal dissemination and then ascites, no, I don't think so. It is a good, I mean, very good choice of patient for a secondary cytoreduction. But the same setting, if they come in as a primary presentation, peritoneal mets with ascites, especially the serous variety, they do come. They present as mimicking ovarian cancer. There, yes, there is a role of NACT and then cytoreductive surgery is there. But in a secondary setting, if performance status is not so good, we don't attempt.
And radiation, madam, to consolidate, if the patient is not fit enough for surgery, do you still refer patients for radiation? Such a patient I'm talking about.
No, not with peritoneal mets.
No, only lymph node mets I'm talking about.
Only lymph node mets, yes, even if we refer, see, external iliac, paraiotic, in 3-4 places are there. Even if we send, I don't think so, our radiation colleagues, they will be willing to give in multiple areas.
Multiple
areas. This is a vault recurrence, isolated or isolated paraiotic, yes, we can consider of radiotherapy there.
Okay, thank you, madam. Thank you. So I think we did talk about it. So the first line for advanced disease right now, it is this was shown by Dr. Shwetha also. Paclitaxel, carboplatin, and pembrolizumab, except for carcinosarcoma. We do have data for carboplatin, paclitaxel, durvalumab for deficient MMR only, and we did see the data for with the combination of olaparib, which had a better benefit with proficient MMR status. We do have multiple other second line chemotherapy drugs, or if IO hasn't been used in the first line setting, pembro plus lenvatinib could be the good option for second line setting. So we have discussed this trial, the DOE trial. So it did include carcinosarcoma, which was not included in the pembrolizumab trial. The only thing is the numbers are quite less, probably 9 in the chemo arm, 5 and 8 in the immunotherapy plus or minus olaparib arm. So the PFS again in the intention to treat population, yes, the triplet did much better with a very impressive hazard ratio of 0.55, and even the OS benefit was shown in the intention to treat population with an hazard ratio of 0.59. The interesting thing definitely, as all of us know, is to looking at the subgroups. So if you look at the deficient MMR status, we know immunotherapy works very well and these guys are resistant to chemotherapy. And as shown here, we can see very similar hazards for immunotherapy alone versus immunotherapy plus olaparib, 0.42 versus 0.91. So, and moving on to the proficient, we know that in the proficient, Durva plus olaparib did well with a hazard ratio of 0.57, and at 18 months it showed a 42% over PFS compared to 20% with just chemotherapy and 31.3% with chemotherapy plus durvalumab alone. So there is good data, statistically significant data probably for the combination of durva plus ola plus chemotherapy in proficient MMR status. So I think starting tomorrow with this particular data tempt you to use the triplet chemo plus IO plus olaparib in the proficient MMR setting, Dr. Supreet?
Yes, sir. Going by the data, yes, and more so in patients with serous histology, probably I would be tempted to use. Definitely, yes.
Okay. And the other histologies with proficient, would you use immunotherapy there, or would you still go by the proficient MMR and be tempted to use olaparib? Because if you see all
Uh,
olaparib data, it's for both high-grade serous and endometrioid type. If you're just looking at ovary and trying to extrapolate it, most of the solo one trial did use endometrioid also. So why not?
True, sir, but I feel the rationale behind using PARP inhibitor somehow I'm comfortable using more in olaparib. I mean, more in serous histology. But yeah, I would like to wait for more data for me to be convinced to use in other histologies as well.
Yes, I think point well taken. Ravi sir, any difference in that, sir, or would you use it for all proficient with the hazards of 0.57?
I agree with Dr. Suprit. Presently, I think I'll be stick to the approved indications.
Okay, all right. So I think this slide has been discussed before. So this also Dr. Supreet had told us for which molecular subgroup do you expect the addition of PARPI to be beneficial? Dr. Rachin, would you want to differ on that, or would you say only for serous?
No, I think I'll wait for more data and see in the real world what is happening.
Okay, I think that will take some time in our country for our real world evidence to come up. So this is again a comparison which was again shown between all the available drugs. We do not have dostarlimab, so it might come in the next few months. But if you compare NRG, GY018 and DOE, not having carcinosarcoma is one drawback of the NRG trial. And with DOE in the proficient setting, it showed very good results. So that would be the advantage. I think the adverse events, we are well versed with managing immunotherapy and olaparib adverse events. So that I think would not be a major concern. Dr. Srivali, do the adverse effects actually cause a problem to you when you think you're going to use the triplet, especially with chemo and olaparib?
Yes, sir, I think anemias, cytopenias will be more. Maybe the Ola, we will have to start at a very low dose and then
No
see how
dose.
it goes.
Yes, I think uh, Ravi sir, you still think there is some unmet need in this management of first line advanced? Do you think ADCs might actually come in here, or what is the unmet need according to you?
Yeah, I feel ADCs should come because the disease biology, though earlier it was discussed that many of the time it is low grade, and but what we have seen is they behave very aggressively. Even in early stages, we have seen. Now only we are treating. The patient is pole mutated. We just kept under observation, but the patient has relapsed. So I think the biology still we have not yet understood, and more prognostic markers should be there, and probably ADCs or some newer therapies will guide us.
Yes, sir. I think that's true. We still haven't got the best biomarkers yet. So I think that would be the last slide from my side. I would like to hand it over to
And Sai,
AstraZeneca.
just to
Yes, ma'am.
complete the session, they tell us about the cost of this immunotherapy, and if at
So
all I have to send my patient to you, then I have to counsel her the cost also.
I think, madam, olaparib, as you know, now
Yeah,
generics are available,
olaparib.
madam.
Yeah,
So
yeah.
I think per month it will be somewhere, if you use the generic 15 to 25,000, I think 600 milligrams, very hardly we are able to use. Durvalumab will be the expensive drug here if you're using the triplet. Durvalumab, I think for a year of therapy, I'm guessing once DCGI has approved this particular agent, it might be somewhere around we'll have to buy 8 to 10 cycles. So close to around 20 lakhs would be the cost of durvalumab. AstraZeneca team can correct me if I'm wrong. Around 20 lakhs for durvalumab, madam, plus, as you know, 25,000 per month for olaparib.
That's fine. Yeah. Thank you.
Thank you, ma'am. Yeah.
So what about you, sir? Are you convinced for the endometrioid variety or you would want to stick to serous to add Durva and Ola?
I think there is synergism in theory. Definitely, there is no denying that when you're using PARP inhibitor plus immunotherapy, there would be more neoantigens which are going to be produced. So, in a proficient case, let's say cost is not a problem. I think putting the best foot forward and trying it is how we are going to learn. I think as you said, I might start olaparib at a low dose, or I might wait for 3 to 4 cycles of chemotherapy before adding olaparib. But as everybody feels, I would like to see more data in that particular setting.
Sir, because the similar rationale in ovarian did not do well. Combining immunotherapy with PARP, both durvalumab and pembro somehow failed there. I don't know what could be the reason. What is it so different in endometrium that they are succeeding, and it is different in ovary that it has failed?
I think that's yeah. Go ahead. Yeah, go ahead.
Sir, I feel immuno never worked in ovary, unlike endometrium. So I think definitely Ola has got some role to increase the TILs and then enhance more immunogenicity and for our immunotherapy to work. That's why it may be working here, unlike ovary.
And madam actually answered this question. Ovary, as we know, it has more of intraperitoneal spread. Again, the delivery of any particular drug to the peritoneum is much lesser than its delivery to the lymph nodes. So I think ovary most probably goes into the lymph nodes, rarely to the peritoneum. So probably that could be one reason. And secondly, again, the microenvironment of the tumor might differ compared to ovary and endometrium, making them one hot and one colder. So apart from that, we don't have better biomarkers to, I think, come up with any hypothesis. Madam, do you agree with that particular thing, why ovary and endometrium might differ in terms of their responses?
Definitely. Rightly said.
Yeah,
So,
I think,
and also second nuance that
I saw HIPEC in this one. Any institute for done HIPEC for endometrial recurrence? As far as I'm aware, I've never come across. We don't do at all. But I think now there are some selected case. Some institute are. I think on a clinical trial basis, they might be doing. Any experience? Any one of you? No.
I think yes, madam, some cases are being done, but they're being treated as peritoneal surface malignancies, especially in if at all there's serious deposits. Selected cases are being done, madam.
And also second nuance that I noticed was in this trial, the durvalumab alone arm as compared to chemo in proficient MMR did not show significant benefit, while that was not the case in pembro plus chemo arm. That again is one nuance that I still don't know why it happened.
That's true. I think immunotherapy has never been an easy drug to predict in which cancer it will respond. Even in certain cancers, different agents of immunotherapy are showing very varied responses. I think it's again patient selection. I think if we start comparing cross trial, I think we cannot come to a definite conclusion. I think treating it case by case patients based on their logistical availability, I think denying them immunotherapy in the first line proficient at this particular point might not be the way to go. And where we are going to use olaparib, probably it's left to us and more data when it comes.
Yes, I think you've covered.
Yeah. Anything else, madam, that you would like to suggest?
No, that's it. You have nicely covered the whole endometrial from diagnosis to recurrence. Nice, and it was nice to see so many Kidwai alumni. So I thank AstraZeneca inviting me here to be a part of this program. Thank you so much. Thank you, Sai, for nicely moderating the session. Thank you.
Thank you, all my panelists, and I'd like to hand it over to AstraZeneca team. And thank you, Niti, madam.
Thank you so much, sir. We would like to thank all the speakers, moderator, and panelists for logging in for today's webinar. So with your permission, we may end the meeting.
Yeah.
Thank you.